So we'll get going. Before we get started, I'd like to introduce Megan Kruger, who is managing everything from behind the scenes, and Andy Richardson. I'm going to cover three key issues today. First of all, what are the roles and opportunities for allied health assistants in the aged care setting? What is the role of AHANA, and what are the current challenges of effectively engaging the allied health assistant workforce? And we'd really value your views and feedback on that. So I'm going to talk through the first section and then hand over to Andy. This is the definition of an allied health assistant that we use in AHANA. Allied health assistants have demonstrated competencies. They can deliver therapy to individuals and groups. And I guess one of the really important things here, particularly in the aged care workforce, is that they're really involved in supporting, restoring or maintaining function of the clients that they work with and promoting independence and wellbeing. So we really try and differentiate the allied health assistant workforce from a personal care workforce. Unfortunately, we still find that the training doesn't necessarily support that. A couple of other important definitions are that they work within a defined scope of practice and they work under the delegation of an allied health professional or equivalent. And we're reasonably loose in those definitions because we don't actually have a clear definition of what is an allied health professional in this country or in most jurisdictions. It's this issue of supervision and delegation that trips over allied health assistant effective use in most contexts. And I guess one of the important things is that the allied health professional does not normally need to be in the same room as the allied health assistant. So we work within a range of models of delegation and supervision according to the risk, proportionality of the risk and the complexity of the setting and the clients that we're working with. So we have examples of effective delegation, which is remote, that sort of hub and spoke model. And in other contexts, it's really appropriate that the allied health assistant is working side by side with the allied health professional. I just wanted to give a little bit of background around why the growth of allied health assistants is so important. Allied health assistants aren't new. They've been around for as long as the allied health workforce has been around, but we've really only started to organise them in the last 20 years. But you'll know, and we know, that the allied health workforce is really experiencing a lot of shortages now. So things that would have previously been done by allied health professionals, we increasingly need to be able to delegate that the lower risk or lower complexity tasks to allied health professionals. I've just got some examples of changes in the number of job advertisements over the last 2 years for a number of allied health professionals that you're likely to be working with in the aged care sector. Top is about 2 years ago from August 2022, and the bottom was taken just last week, and then the middle one was taken last year. So this is for speech pathologists. 2 years ago, the number of jobs advertised on SEEK were about 1,800, and you can see that's gone up by about 400 in 2 years. It gets worse. Occupational therapists, there are about 5,200, nearly 5,300 job advertisements 2 years ago. That's gone up to 6,730 last week. So that's quite a large increase, nearly 1,500. I guess it's worth noting the size of these workforces. Speech pathologists are a self-regulated profession. We estimate there are between 12 and 15,000 of them working in the country. Occupational therapists are an AHPRA-regulated profession, and there are, from memory, about 35,000 of them. Physiotherapy is a very big profession, over 40,000 physiotherapists, but you can see the job opportunities or job advertisements 2 years ago, 4,600, and they've gone up by just under 1,000 in that 2-year time period. And that's actually quite notable because there are well over 40 physiotherapy programs in the country at the moment. So we've seen an increase in the number of graduates, an increase in the number of courses, but we're still seeing an increase in the number of job advertisements for physiotherapists. This is the one that's most striking, which is the increase in the number of jobs for social workers. And I'm not sure how many of you would be working directly with social workers in the aged care environment. I suspect quite a lot in the community setting. But a number of job advertisements 2 years ago, nearly 4,350, and that's nearly trebled in that period. Now, there are probably some issues around classification. It's a self-regulated profession. Don't know exactly how many social workers there are. About 20,000 registered with AASW, but possibly twice that number working in the community or in different contexts. But it's still a huge number of job advertisements and unfilled roles. So this is where allied health assistants really come into their own. But again, in the last 2 years, we've seen not quite a doubling in the number of job advertisements for allied health assistants. So what we know is that there is a huge shortage of allied health professionals across the board. We assume that's largely been caused by the rapid growth in the NDIS, but not only that. You know, there have been issues around recruitment and around retention as well. But there are opportunities for allied health assistants to step into that space. And what we're interested in from the AHANA perspective is how do we take this diverse workforce that could potentially work across 30 different allied health professions and create a consistent structure that is quality assured. And Andy's going to talk about that a bit more. What can allied health assistants do? You probably see a number of different roles. And as I said, there are probably as many different tasks for allied health assistants as there are allied health professionals. I've just taken an example here that I think really illustrates the way that we can use allied health assistants quite effectively. It's a 10-year-old project, and it was actually developed in far northern Australia to meet workforce shortages in rural and remote areas. But the models are valuable. The problem that they were trying to solve there was in smaller communities, say a population of 2,000, you can't have, there just isn't the population to sustain one individual allied health practitioner. One OT couldn't sustain an appropriate business model in a population of 2,000, let alone a multidisciplinary team, which we know we need. So the model that this project was trying to address was developing interprofessional or interdisciplinary practitioners, so allied health assistants and other practitioners that had a range of skills that they could use in their rural and remote communities. They used a framework called the Calderdale Framework. I'm not going to go into that in any detail, but what it did was, first of all, look at the skills and tasks that could be delivered by a range of allied health professionals in those communities, and also look at the needs of the communities. And so it started to look at how the tasks of the workforce could match the needs in those rural and remote areas. There were 6 professions included in the scoping, and they identified 337 unique tasks, and I'll show you what those look like in a moment. And what was interesting, 127 of those tasks could be shared across all of those, or at least some of those professions straight away. Apologies for the formatting, it keeps going out. So you'll see that one of those groups was allied health assistants. I keep this slide in just because I think it's interesting. What I would have expected, this shows the proportion of the tasks that were unique to each occupational group within those 6 professions. I would have thought that physiotherapy would have had quite a lot of tasks that were unique to them, but only 26% of the tasks that they identified of those 300, 26% were unique to physiotherapists. Conversely, I'd have thought that occupational therapists would have much more unique tasks, but actually there wasn't a lot of difference. Only 20% of tasks were unique to occupational therapists. This is important because what it shows is, and it's a challenge for workforce planning for allied health professions anyway, is that there's a lot of opportunity for overlap in our skills portfolio, which is an opportunity, but it's also a potential threat to the professions, but it is a challenge to accurate workforce planning. So when they took those 300 or so, I think 326 tasks and put them back together, instead of putting them back together around professional roles, they put them back together around functional categories. And all of the categories that I've highlighted here in purple are relevant to the aged care sector. So what we can see is that there's a bunch of skills and tasks that are general to the allied health workforce, and we can pull these back together in a way that is not discipline specific and can meet the needs of your communities. Activities of daily living, mobility and transfers, mental health, fatigue and sleep, pressure care, diet, nutrition. Note that there weren't any nurses in this group, so these were all allied health professionals, continence assessment and basic intervention, but there are others there as well. I apologise for this slide. I literally cut and pasted it from the report and it wasn't that great initially. This report was not specifically done for allied health assistants, but what they found was that of those 300 or so tasks, nearly half of them were able to be delegated to allied health assistants, but actually only 47 of the tasks were, and that's because they didn't have great supervision or delegation frameworks. So these were the tasks that were actually delegated, and I'll just show you on this slide the potential tasks that were available for delegation. And again, I apologise for the quality of the slide, but The point I really want to make out here is that none of these are discipline-specific tasks. They're all are based around functions, activities of daily living, things that are not discipline-specific. So this, I think, gives a really good example of the types of skills and tasks that can be delegated to allied health assistants, and they can be rearranged in a flexible way that meets the need of your client group, or patient group, resident group, and the context or settings in which they're working. So allied health assistants have the potential to be really quite flexible to meet the needs of your clients. I'm going to hand over to Andy now to talk a bit about the role of AHANA. Thanks, Andy.
Thank you, Susan. So the main purpose that we as AHANA are offering to solve in regards to the AHA workforce is we provide quality insurance. We understand that there's current uncertainty around lack of consistency of standards, and we're doing what we can in order to overcome that and make sure that that is clear and concise. We provide clarity around risks for employing and working with an AHA. We're building the AHP workforce capacity by allowing better access to more patients more often, and we're assisting to build up shortages within that workforce. So for those of you that aren't aware of us, we are the peak body for AHAs. One of our main projects we've been doing is our AHA certification scheme. So it's our quality assurance of what we expect for practicing members within our association and what you can expect for businesses by joining with us. We support, promote, inform and advocate for AHAs all over Australia. Okay, so how do we provide that assurance? We improve the quality and safety for practicing AHAs by making sure that we make sure they abide by standards of entry, they have relevant qualifications and experience, they abide by our code of conduct. Our association also offers them insurance if that is so required. We give them opportunities to access continuing professional development. We have a complaints procedure and we provide access for peer support. So we just wanted to put this up more so to show that we do have a structured membership options available within the association itself. All our practicing members are divided based on their amount of clinical experience and their relevant qualification in relation to that clinical experience.
I'll just address one of the questions that came up, Andy, before the session. Yeah.
Of course.
So just to give you an example, I guess what's really significant here is we've taken a very complex workforce. So we've used the same principles that has been used for all of the other self-regulating professions, speech pathologists, dietitians, exercise physiologists, and we've used world's best practice. The association policies and procedures and the structure was developed by Dr. Anne-Louise Carlton, who was formerly with AHPRA and has recently led a World Health Organization review of the health professions regulation. But what we want to show here is that one of the concerns is that and we're seeing this particularly in the disability space, membership of an association will be restricted because we don't have a standard qualification. So what we've had to do is ensure that anyone who's currently practicing as an allied health assistant is eligible for membership, as long as they agree to adhere to our code of conduct and are covered by appropriate insurance and so forth, the points that we covered in the previous slide. So they agree to adhere to continuing professional development and so forth, and they'll be subjected to our complaints procedure. So any currently practicing allied health assistant can become a provisional member, but we've got tiered membership based on the qualifications. So our highest qualification, which is the certified practicing member, that person has to have a certificate 4 in allied health assistance. We do get queries from other groups with other types of Cert 4, and a specific one that was raised for this group was, are those qualified with a Cert 4 in leisure and health considered allied health assistants? If they're working under the supervision and delegation of an allied health professional, then yes, and agree to adhere to those standards that Andy previously raised, then yes, but they would meet our practicing member general class because the Cert 4 in leisure and health isn't specific to allied health assistants. So that's just to give you an example of how we map some of the qualifications. We get all sorts of qualifications and they go through our membership and certification committee for equivalence here. Back to you, Andy.
Wonderful. So some of the challenges that seem to come up from employing the AHA workforce, next slide, uncertainties around delegation and supervision frameworks and lack of efficiency. We are aware that there is a potential project for a national equivalent scope of practice, but it's still in the early stages of consultation. So that's unfortunately not going to do anything to aid you in the short term. So efficiency of the workforce is more to do with the understanding of the health professionals that you might have on the ground and how they understand the role of the AHA and to be able to delegate appropriately. Lack of clarity around insurance, and we've provided consultations earlier in the year in regards to try and give some more education in that space around whether AHAs do need additional assurance or not, and we can offer that to our members if they so require. Confusion between employment and clinical governance models, and AHPs that are poorly engaged or very protective of the skills and tasks that they already seem to do, without the understanding that by delegating those low to moderate risk tasks to an AHA, they're actually freeing up the health professional to focus on more complex specific tasks that can increase quality of job satisfaction and all those wonderful things.
Can I just touch on the third point, because that's a big issue that comes up. We see it more in the disability space, but a lot of allied health assistants are going out and setting up business with their own ABN, so they're self-employed, so they're not employed by an allied health professional. And one of the challenges that we're seeing is that the allied health professional believes that if they're not directly employing the allied health assistant, that they're not supervising them or delegating them. So that is incorrect. It is possible to have an employment model that is separate from a clinical governance model. It's possible to provide clinical governance and supervision without directly employing the allied health assistant, but it requires clear structures and paperwork to do that. So we just want to raise that because it does lead to a lot of inefficient employment of allied health assistants if the allied health professionals won't employ them because of that concern. Right, back to you, Andy.
One of the big ones, we've recently been excluded by the National Allied Health Strategy. We're not going to be included in the initial framework, although we have been given some assurances that themes of allied health assistance and the effectiveness on the overall workforce will occur throughout. Training is largely based on the nursing personal care models and not specifically allied health and reablement. I myself started in residential aged care, and the opportunities within the space were very limited. It was only 1 to 2 days a week where you offered ability for specific functional activities or group exercise classes, and we're aware that there's more effectiveness that can be utilized with allied health assistance within that space, especially with an MDT model. There's no way to say that you can't separate tasks during the course of a week. So 2 days a week, they're focusing more functional complexities like mobilizing and sitting and standing, and then other days during the week doing activities of daily living and those kind of things, in order to give them back more independence and more dignity within the smaller areas, so that they're reducing the amount of physical burden on the already significantly stretched aged care workforce. And also poor career progressions and lack of articulation pathways, because varying on the sector, there's a lot of inconsistencies around what progressions are actually available for allied health assistants based on where they're working. Next slide, please. So the opportunities that we've been trying to create as the National Association. So we're recognising certified allied health assistants within aged care and the disability funding models. We submitted a co-regulation proposal to the Commonwealth Health Minister to try and advocate for AHAs and give them access to fee-for-service funding. We've taken part in the primary health scope of practice review and supporting effective delegation for allied health assistants. We're supporting the AHA career pathways and trying to coordinate with vet and tertiary institutions to set up degree type apprenticeship models so that they can use the role of the allied health assistant in order to improve the amount of clinical experience they can get while they study, while they're receiving employment, while they're completing their qualifications. And then, of course, competency-based training support, skills and skills passports.
So if you want more information about AHANA, you can either scan the barcode or go directly to the website. But we've got some time now. If anyone's got any questions, feel free to throw them in the chat. There are a couple of other questions that came up, Megan. I'm not sure whether you want to pop those in. Yes. Okay. So one question that we had is about how allied health assistants can be used to support podiatry and what qualifications are required for an AHA to work under podiatry and aged care. That's a very good question. There is a national skill, what do they call the national skills for podiatry? But as far as we're aware, no one is actually offering that particular qualification at the moment. I'm going into a meeting in an hour with University of Southern Queensland because they've recognised that foot care support is really underutilised, and we also submitted a specific proposal to government to try to get at least a pilot up for foot care assistants. Charles Sturt University has, I think it's an associate diploma in foot care, which is a career pathway into podiatry. They're looking at trying to get funding for people to go into that. We know it's a huge problem. And look, what we're trying to do, and we met with the Chief Allied Health Officer last week, work with universities, the public and private sector to at least get some pilots up around this and start to get some micro-credentials around foot care. Emily, did you advertise specifically for foot care, or was it more part of a general allied health assistant role? Because we know I'm a podiatrist by background.
Yeah, so it was specifically for podiatry. It was in a challenging area, Ballarat in Victoria, which is typically difficult to recruit for any role, but we did look for specifically allied health assistant with podiatry specific education.
That's useful for us to know. That's actually the biggest gap that we're hearing about. And we've also talked to the Podiatry Association. Part of our proposal to Mark Butler was to try to get some funding specifically for foot care allied health assistants to work in the podiatry space. But look, they've all been bundled in together with allied health, and I just saw that any changes to Medicare funding are going to be delayed by 12 months. We might come back to you though for some support for lobbying in this space. It's obviously a huge area. I think we probably need to do a bit more work around it.
And currently with the changes with the new AHA training package, it's a very MDT focused more so than anything else. And I've tried looking around the place, and there's very limited options for foot health specific skill sets, primarily for AHA. So we've even had difficulty down here. I'm employed in public health in the ACT, and we've recently had difficulty trying to recruit into our roles. And then, of course, that's also because ACT doesn't have access to a podiatry degree within the state. So we were trying to find other avenues in order to try and pull interested people across. So we ended up expanding as wide as the Bachelors of Health Science in order to get some interested health professional students that want to get involved in healthcare and provide all the upskilling in-house.
Yeah, it's a big issue, but I think, everywhere we go, we're hearing that it is the biggest problem. When I was a podiatrist nearly 30 years ago, it was the largest source of ministerials. I was working in the ACT at the time. So, it's still a big area of need. We'll come back to you with solutions if we find any, Emily, but yeah, good point.
Thank you.
Thanks. Fiona or Sarah, do you have any questions or any other questions from you, Emily?
I guess I work with a team of allied health, lots of different disciplines, and I guess we've also looked at using AHAs for physio and OT, and definitely can see how they'd be really useful there. But I'm just a bit curious with social work. It's not something we've really considered. We do have social workers, but I haven't really thought about how allied health assistants might be useful for working with them as well, if we happen to have any examples.
I don't off the top of my head. Do you know any, Andy?
Well, down here in the ACT, so we have the largest, they classify themselves as largest department of social work assistance in any state in Australia. They're split between our acute and subacute teams, and we've got seven social work assistants in total. The only difference with them is they're considered more of a senior AHA role. So this is within public health, but they're doing everything from the bedside advocacy and support for patients, as well as their transition for services within the community itself. So there's nothing to say that there isn't access for social works to be able to utilise an assistant model. It's just based on the models that are currently available. You'd be looking less at a recent graduate AHA with no clinical experience. You'd be looking at someone a little bit more experienced, because the model of those that seem to step into the assistance roles within social work anyway is the graduate of social work, and the first job they'll get a job as like a case manager working out in the community, and then they'll work for a couple of years building up their confidence before they step into social work roles anyway, because social work is incredibly strict and structured in the way that you have to get certain certifications in order to be able to work with certain demographics of the community. So I believe it's around 2 to 3 years you need to be practicing as a social worker before you're eligible to be able to work within mental health, because you need to have those underlying skills and knowledge and competencies in order to be able to practice in that space.
So that might be a useful case study for us to get going within AHANA, Andy, some case studies of how different professions are using allied health assistants, because I agree, Emily, that's one of the, it seems in that sort of social and the psychological care space, we're not as good at identifying tasks that allied health assistants can use. So maybe we should come back to you, Andy, and look at how those social work assistants or allied health assistants in social work are being used, the kind of tasks and competencies they've got.
Psychology is another one like that as well. We've started getting a little bit of a boom of psychology assistants being able to aid in that first stage of mindfulness and support, while getting specific guides in place as to how to direct a conversation so they can pull relevant bits of information to the health professionals while sticking away from any red flags that would be too much around their clinical knowledge for them to be able to intervene.
Feel free to get in touch with us at any time, obviously, through the AHANA page if you've got more questions, but they're actually really useful questions for us, Emily, so we can take those away. And it's AHANA is relatively new. Trying to bring this together as an occupational group is quite new, so it is useful for us to understand the issues. Any other questions or concerns? They're great questions.
I don't have a question, but I'm interested in like that social work sort of side of it as well, because in our multi-disc team we have a social worker, but we never get any tasks from her, just generally because they would think it was like not within our scope. We'd have to go get extra sort of training and stuff. So that's interesting to me to hear how other places work. We do very minor things, but nothing specific.
Social work was included in that Queensland study, and I can pull out the specific tasks actually that were deemed eligible for delegation to allied health assistants. I mean, the context will change, but look, I'll throw those in at the end. In fact, I can put the link to that resource in the chat so you can have a look yourselves, but that might be useful as well. Here is the link. That has a breakdown of, it's one project in a rural and remote area in Queensland, so the issues won't directly be, here we go, social work. All right, I'll just show you what they deemed as appropriate delegation from the social work perspective. These are actually tasks that could be shared rather than necessarily delegated to an allied health assistant. But it shows that there are, oh gosh, yeah, they're so non-specific here. If you look down in the text, so they've got psychological assessment, cognitive behavioural therapy, counselling, assessment of parenting skills, end-of-life planning and support. They currently delegate 2 tasks to allied health assistants, facilitating client engagement and group facilitation. So at least, there's something there. And like I said, that's 10 years old. I think things would have probably moved on in that time. So, but yeah, thanks. I think that's something that we need to be looking at providing more information about from a AHANA perspective. Any other questions? So thanks so much for contributing and participating, everyone.